everybody, it's Dr. Linda. Welcome to our monthly VBF Facebook Live. Today's session is with world-renowned Sturge-Weber Syndrome expert, Dr. Ann Comi, who is the director of the Hunter Nelson Sturge-Weber Syndrome Center at the Kennedy Krieger Institute. I got that all out. So I hope you all had a great Thanksgiving, and thank you for being here with us again. It's becoming our annual Sturge-Weber Syndrome Facebook Live session. So you all know, hi April, hi Erin. I see some people are on, 9 people already. And we are here for 1 hour, and Dr. Comi will be answering your questions relating to Port Weinstein, Sturge-Weber, and as soon as you start posting your questions, we will be answering them. Facebook is a little wonky today, so just bear with me. It looks like we already have one. Oh, I think that's just from April. I'm not seeing that comment, April. I see there's already one comment, and it's not showing up. So let me see if it's on here. Let me see if usually the live will pop up on here, because normally the questions should be showing up. We have 11 people. See, there's comments coming in and I'm not seeing them. So let me see. Sorry, everybody, we're dealing with, oh, here we go. I'm seeing Corinne is on and April, but I'm not seeing any questions. So if you guys could just post a question like, hi, we see you, or whatever, just so I can see the questions coming in. I see here we are on here. Let me see if the questions are, okay, let me just turn the volume off. Okay, so hello from Seattle. Hello Boban is watching. So apparently we don't have any questions, but let's start with the questions. Your Sturge-Weber or Port Weinstein questions next month, Facebook Live. Hi, Sergey, and Megan, hi. Okay, Tucker and I are tuning in. Megan Lewis, Susan Klingbeil is watching. Hello, everybody. Dr. Comi is here, ready to take your questions. Remember, we only have an hour. Next month, we'll be with Leslie Graff, and we'll be talking about the psychosocial issues of living with a vascular birthmark, especially through the holidays and how that may affect it. So Renata is saying hi to you, Diaz. Okay, Ricky LaPrade has a question. We saw Dr. Comi Friday, and she was great. We will be back in July. We appreciate Dr. Comi's dedication to this small community of families. So that's Ricky LaPrade. I don't know if that sounds
Thank you.
Oh, so Sergey and Dr. Duarte are in Aspen. So they're saying hi. They're just rubbing it in a little. In that wonderful, beautiful snow. So hi to our colleagues. Okay, so Alina's on now. So let's see some of your questions. Hello, Renata from Argentina. Anna Fox. Dr. Comi is right here, ready to answer your questions. We worked on a little bit of fact sheet today too on Sturge-Weber, which we will be posting. And I think it's important that all of the families that have a child with a Port Weinstein get accurate information, because there is, you and I have just talking about this, the persistence of the level of inaccurate information. It's like astounding. So let's see. Okay, we already got that one.
Does anyone have any questions for me?
Yeah. That's right. They're all saying hi, and this typically is what happens. They start logging in, but yeah. So we would like some questions on testing for Sturge-Weber, what to look for. I mean, we can start talking about this stuff, but it's better for you. Okay, Meetup's from Turkey. So your questions regarding Port Weinsteins and Sturge-Weber, but this does happen. Okay, so go ahead. You can start posting your questions. We've been on for 4 minutes. And I'm seeing that there's 23 people on. Now, if you're writing questions and I'm not seeing them, that's another problem. But I am seeing your hellos. So I think your questions should be popping up. Questions relating to hello from Albania.
I can take questions on prognosis or on the use of cannabidiol, perhaps, in the treatment of Sturge-Weber syndrome, if anyone has questions.
Okay, here we go. A question. Megan Lewis says, when they turn a year old, what do you do as far as their MRI? It shows brain extent, but what are the seizure rates after a year?
Okay, so I'll try to take a stab at that. I'm not entirely sure what is being asked, but let's say the child has not had any seizures yet, and the MRI is diagnosing brain involvement. After a year of age, there still is a fairly high risk of seizures. Most children will begin having seizures before 2 years of age, so 85% of children will begin having seizures before 2 years of age, but then even after 2 years of age, 10, 15, 20% of patients will begin having seizures after 2 years of age, and it can be as children, as teenagers, as adults. The oldest patient that I ever took care of had her onset of seizures in her 60s.
Wow.
So there can be a big range.
That's a great answer. Heather wants to know, what are some of the misconceptions about Sturge-Weber? I think that's a good question.
Yeah, I mean, I think sometimes parents will go online and see really difficult things happening with patients or more severe outcomes and not realize that there's a huge range to prognosis. So I have patients who have just well-controlled epilepsy, and they're have families, and they're working and living independently. And Sturge-Weber syndrome can range everywhere from that to much more severely affected. And we know that prognosis in part depends on extent of brain involvement. So the brain involvement can range from just a small area in the back of one side of the brain all the way to the full involvement of that side, to involvement of both sides of the brain. And so prognosis depends a lot on that, but it also depends on the age of seizure onset. So the earlier the age of seizure onset, typically the more severe the outcome. Also, we're beginning to learn that family history can also impact prognosis. So things like family history of epilepsy or migraines or stroke. Early onset of stroke also can impact prognosis somewhat in the child as well.
Oh, that's interesting. Gina from Ireland wants to know if she can send her son's records to you to be reviewed. He has port wine, V1, V2 brain involved. She's in Ireland and there's no one for them.
Yes, I do chart reviews, and if you reach out to me, my email is Comi, C-O-M-I, at kennedykrieger.org, or through the VBF directly. Right. I'm sorry.
Yeah,
probably the best way to do that.
She's right on our front page of our website.
Yeah, could do it that way.
Yeah.
And we work together, reach out through the VBF. Mm-hmm. That can be arranged, yes.
Okay. And Erin wants to know, what are the signs of Sturge-Weber syndrome?
Signs of Sturge-Weber syndrome in a baby. So I tell parents to look for things like, so they can have a visual gaze preference, meaning that if the birthmark, say, is on the right side, then we worry about brain involvement on the right side. And so they might have a visual gaze preference where they decide, or they're unable to see off to the left, and so they look only to the right, or turn and bring the right visual fields out and start looking with the head turned. So they might have a visual gaze preference. They may also become handed early. So just stop using one side, children shouldn't become handed before a year of age. So becoming handed very early, we're all, or not all, but most of us are right-handed or left-handed. So becoming handed very early can be a sign of Sturge-Weber syndrome. And then of course, epilepsy. The most common presentation of Sturge-Weber syndrome brain involvement is seizures. And the seizures are typically not big sort of tonic-clonic seizures like one sees on television, but more focal seizures with repeated twitching of the hand or the foot, not just a couple twitches, but going on for a minute, 2 minutes, 3 minutes. It can be a head turn with the eyes deviated and bouncing. Again, not just a couple twitches, but going on and on and on, or the eyes just deviated and fixed and not moving. And so if you see that and you can't get it to stop, then that's most likely a seizure, and the child should, get urgent care.
Okay, so Susan's got a good question. Her son's 3, has had 19 laser treatments, and she's going to start with the Prima, which combines the YAG
Yes.
and the PDL. And her concern is it goes a little deeper. Is that going to have an adverse effect on his condition, she said?
There's no evidence that getting laser adversely affects either the brain or the eye. We and others have studied that by doing chart reviews retrospectively, and also we did laser treatments and looked at how that affected the pressure of the eye, and the pressures actually went down a little bit. So not that we're aware of, there doesn't, and so we do recommend going ahead and getting treatment early.
Great. So Ricky says that he read a study, only one study done on 52 adults with Sturge-Weber. He wants to know if there are any other studies out there on how they were affected with aging.
Yes, well, I'm not aware of any other study specifically directed just at adults. We do see adults at our center, and so we have adults incorporated into many of our studies. Yes, you're right. There's not a lot of studies specifically geared at outcomes just in adults.
Maybe something we could look at. So Zenling Jiang wants to know, how could you please comment on the exact mechanism of how aspirin helps as pre-symptomatic treatment?
So we just published a paper using both aspirin and seizure medicine as pre-symptomatic treatment. So aspirin is used because it interferes with platelet function just a little bit, and so it thins the blood just a little bit and helps with blood flow. That's the thinking. And in Sturge-Weber syndrome, there's evidence that it helps both in preventing strokes and stroke-like episodes, but also in preventing seizures. And so we have used, and we have some beginning evidence, early evidence, that the combination of low-dose aspirin and a seizure medication, and typically either oxcarbazepine, that's trileptal, or levetiracetam, that's Keppra, combining that with low-dose aspirin is effective in preventing or delaying seizure onset and improving neurologic development and outcome. And so we published our very, very early data on that, and we continue to study that. And I think that is an approach that many groups are very interested in pursuing and understanding what's the best way to do pre-symptomatic treatment.
I like that. So Mia writes from Sacramento, our son has been seizure-free on trileptal for 2 years. Should we think of weaning off of meds? Our son is 5. I'm nervous because he has had a 13-day stretch of seizures that brought many delays and setbacks. FYI, we are seen at the UCSF.
That's a really difficult decision to make. And I do sometimes have that conversation about 5 or 6 years of age. The harder it was to control the seizures and the bigger the regression at the time that the seizures had, the more likely we are to be very cautious about withdrawing the seizures. Also, the more brain that's involved, so the greater the brain that's at risk. If you start having strokes and stroke-like episodes, the more cautious we're going to be. So I, without knowing all the information, I really cannot give you information for your son. Okay.
Really
I really
email you.
Yeah, I really can't sort of, without having a full, all of the information. I can't do that. Sometimes parents will just continue treating. Other times they may just very, very slowly just begin to wean the medicine by not increasing the dose anymore. So as the child continues to grow, if you don't increase the dose, then they are slowly weaned over a period of years. Other times we do get an EEG and then wean off. But without knowing all the information, I really can't guide you.
Okay. Christina McLaughlin, go ahead and submit your question. She said she has a question. And then Mentor, who's from Albania, wants to know when we're bringing the team there because they need information, which the closest we're going to be getting to that in the next few years is Serbia. So we will be bringing a team to Serbia probably in 21. I'm working out those details right now. So, okay. So Christina, we're just waiting for your question. Okay. Lisa just submitted one. Our 9-month-old son has a port wine stain on his left side of his forehead and upper eyelid with a line going to his head. He is ahead in his milestones. All eye checks have been normal and no seizures. Our doctors, including you, Dr. Linda, and Dr. Wabel, think he won't get Sturge-Weber syndrome. I know there are risks with getting an MRI. Do you always recommend it, and with no symptoms, and at what age?
I always recommend getting it at some point after a year of age, because at some point your child is going to want to do things like maybe play soccer or some other sport where there's a risk of injury to the head. And that would not be recommended if the child has Sturge-Weber syndrome. There's certain activities that you're going to want to avoid if the child has Sturge-Weber syndrome brain involvement. And you're just going to want to exclude that. And the only way to exclude it is to get the MRI done.
Yeah, and you explained something to me earlier today that now I really understand it, which is how the brain develops before age 1, and that it's best to wait to age 1 to get that first MRI done, not really before that. So it's just not indicative, right?
So very, very early imaging in the first few months of life can be completely normal. And so if the child has a very large bilateral birthmark and a risk of Sturge-Weber syndrome brain involvement of 50%, then I can understand how sometimes the parents will want to get imaging done to try to make the diagnosis, maybe get started on pre-symptomatic treatment. But one has to understand that very early imaging does not exclude brain involvement. And so it has to be, if early imaging is done, it has to be repeated after a year of age. If it's never been done, and to exclude brain involvement, which again, 15 to 20% will have onset of symptoms 2 years of age. And so if it's not been done after a year of age, that child can still have brain involvement, and that will always be in the back of your mind as a risk. And you're going to want to exclude that so that it's not affecting choices later for activities.
Yes, just peace of mind to have it. So Christina, her question is very difficult, if not impossible for us to answer. So her and her daughter's father are separated, and they have to make joint decisions on medical treatment. So I guess she wants laser and he doesn't. There's really nothing we can say or address about that. But the reason, and she's asking, like, why should we start these laser treatments now? Like, what's the benefit? Is it going to help the port wine stain? And we talk about, the thickening of it and trying to get rid of it as much as possible for the whole psychosocial thing, but that the skin thickens. But we really can't address, if they have joint custody, they have to resolve that. Oh, and she said she had a birthday fundraiser for VBF and I gave to it. So, okay. And then Zenlin said again, hello from Atlanta. Could they still get continued developmental delays from brain involvement even with seizure controlled or with no seizures? I guess she's saying maybe cognitive impairment.
So we know that the risk of cognitive and neurologic issues is much, much lower if the patient does not have seizures. There can still be much milder, much milder cognitive delays or learning disability if there are no seizures, but typically it's much milder.
So Renata wants to know, Diaz, is there any other procedure other than embolization? Is there any other procedure? Are they doing embolizations? I don't know what that's related to for Sturge-Weber. I've never heard of that.
Think.
Yeah. I don't know. I don't know. We don't know what you mean, Renata, because we don't see embolizations for Sturge-Weber. It just doesn't really correlate. Okay, thank you. Okay, so next part of my question. This is Lisa. Hi again, Lisa. Our son had a normal MRI when he was born. Mm-hmm. We live in South Florida, but have family near Baltimore. Is it better to come up to you during vacation to get the MRI or get it at any hospital?
So it can be done at an academic hospital. So if you have a university hospital near you, they should be able to get, and I can, if you do, for example, do a chart review or contact us, we can send the sequences that should be done. That's the most important thing, is to make sure that they do the contrast and then do the appropriate sequences so that it's optimal to be able to pick up the Sturge-Weber syndrome. If you come up here, then we would have to make sure that your insurance will pay for it to be done. We get our imaging done at Johns Hopkins. We just would have to make sure that gets cleared.
Wouldn't it also be an option for her if she emails you, you can make sure she gets the right study done, then comes up and sees you with it.
That's right.
And make a consult with you.
That's right.
That would probably be the best.
And we can also, so then I can view the imaging, and if there's any question whatsoever, we can get a consult of the pediatric neurovascular radiologist that I work with at Hopkins. If you bring the imaging with you.
Okay. So an interesting question. Does the cold, snowy weather affect the port wine stain, or is it just the sun?
No, it can. So we often see the birthmark responding in sort of the opposite way that normal skin responds. So, for example, usually skin will sort of become paler in the cold because the blood vessels constrict, and oftentimes the port wine birthmark will get darker because the blood vessels dilate. And oftentimes in the heat, we flush because the blood vessels dilate to try to release some of that excess heat, and the birthmark will sometimes fade. And we think that that's because we know that the abnormal blood vessels in the port wine birthmark are have abnormal innervation.
I was going to say it's an innervation phenomenon.
Yeah. So, and the autonomic response to the hot and the cold is abnormal.
Right. That constriction and dilatation. Lee Chen says, hi from Atlanta. If the Sturge-Weber syndrome patients don't have seizure, does the brain atrophy still occur?
So I have seen, usually not. Usually it's very stable over long periods of time. I've seen a handful of patients over, many patients over many years where unexpected atrophy has occurred. And I can't say that I'm entirely sure what that relates to. I suspect that it may be, and this is perhaps something that should be studied, that patient may have genetic risk factors for hypercoagulability or stroke. But most of the time, even when patients have intermittent occasional seizures when they're older, if you repeat their imaging is unchanged. So, yeah.
That's interesting. So Christina asked another question, and remember, her daughter's only 4 months old.
Okay.
So she said she had an MRI and it showed no signs, but can she still have it when she gets older?
Absolutely can. Yes. The early imaging can be completely normal.
That.
Yeah. And we don't know, again, we don't know for sure because multiple groups are working on an animal model, a mouse model, model, a real Sturge-Weber syndrome model, but that's still a work in progress. So we can't sort of open up the head and look at the brain and know for sure. But there were SPEC studies done in babies under a year of age many years ago that showed that blood flow of its first year of life goes down. And, based on our current understanding of things, we think that probably what is happening is that there is decreases in blood flow, increases in venous congestion, and decreases in the blood-brain barrier, so that whereas in the first few months we can't see those abnormal blood vessels, they're there. And as the blood flow goes down, the venous congestion goes up, and the decrease in blood-brain barrier happens later in the first year of life. Now, if you repeat the imaging then or after the first year of life, now we can see the abnormal blood vessels. They were there before, we just couldn't see them.
Okay. Chelsea said, my almost 3-year-old has had 3 brain MRIs with no Sturge-Weber. However, he is missing a tight jugular. His neurologist, this is a long one, wants a 4th one. However, they all show the same result. They were done at Children's in Dallas. Do you think he needs a 4th? Besides his port wine saying he is speaking and developing perfect. The results from the last MRI at 18 months, MR venogram again, demonstrates diminutive superior ophthalmic vein on the right, as well as absence of the right sigmoid sinus and jugular vein. There is relative decreased prominence of the veins along the anterior temporal convexity on the right, as well as prominent enlarged superior. How could they say there's nothing? On the left, which extends inferiorly to drain via collaterals in the neck. It's like, what? I don't understand how they're.
So it sounds like they're saying there's no leptomeningeal angioma, that there's abnormal venous drainage, and this could represent some very mild variant. If you send it to me, I could try to have our pediatric neurovascular radiologist take a look. I agree with you. I don't think that there's any benefit in doing it yet again. We are beginning to recognize very, very mild variants of Sturge-Weber syndrome. And so it may be that what you have is a very mild variant. So, if you get in contact, we can see if that's what you're dealing with. And if so, then there can be some later issues that we see as the child gets older.
Well, too, it's like the 2 things. One is the imaging and how good that is, and then the reading of the imaging.
That's right.
So I think it's a good idea if you contact Dr. Comi through the foundation and send the imaging. She just may need a different type of imaging.
Well, that's true too. So but that's the other thing is, there's many kinds of sequences on MRIs. So sometimes what may be recommended after, if you contact me through the foundation, would be that there's some kind of sequence that wasn't done previously, that after I review it with our neurovascular radiologist, we might recommend that if it is done again, that some additional sequences would be done.
Great question. Ricky wants to know, his child has been diagnosed with Sturge-Weber, I believe. So he wants to know which sports things other than soccer should they avoid? Like which activities?
Yeah, so we discourage like football.
Kickboxing, kicking to the head.
Yeah, we discourage. Soccer when they're little, is not a big deal, but pursuing soccer to the point where they're heading the ball and it's a serious thing would, not be a good thing, because we know that these patients, when they have blows to the head, or you can't put the child in a bubble or a glass cage. But we know that some of them, if they fall and hit their head or they have a blow to the head, that will trigger a migraine-like issue, can go into seizures, can go into stroke-like episodes. And so we're not going to encourage them to go into activities where blows to the head are just part of the activity. The other kind of activity which we tend to discourage is ones where they're going to be upside down for prolonged periods of time. So
maybe gymnastics.
Well, yes. I mean, but there are different kinds of gymnastics.
Yeah, like the flipping.
Right. So a very brief upside down probably is not a big deal, but prolonged periods of being upside down, just because there at least theoretically that could be an issue for some children, because venous stasis is an issue in Sturge-Weber syndrome, and so being upside down is just adding to the venous pressure and preventing venous drainage from that area of the brain.
And when Dr. Tom Brees and I were seeing some patients in London recently, that was another thing I had. We were talking to a parent of a child with Sturge-Weber, and it was my opinion that, because he's like, well, he could just wear a helmet, and I said, I don't think that's the issue. I think it's even a blunt trauma to the head. So the helmet protects against one thing, but it's really not helping. Correct? Because I mean, based on what Sturge-Weber is, it seemed to me like you don't want any blunt trauma.
Well, I mean, even players in football wear helmets, but they still get concussions.
And they get traumatic brain injuries.
Right.
Yeah. Okay. I'm not sure what Gina is asking. In the early MRI with image of brain involved can change to normal in the future? Oh, can one that shows some brain involvement end up like reversing itself? No,
it can change in the sense that we have some patients who show the abnormal blood vessels on the surface of the brain, the leptomeningeal angioma. As the patient gets older, that can go away, and then we see increase in deep draining vessels, and we think of that as compensatory or as a good thing, because probably what's happening is those are collaterals, deep draining collaterals that are improving venous drainage from that area of the brain. And so sometimes we do see that change, but it's not really going away. It is a compensatory change in the imaging, but that area of the brain is still involved with Sturge-Weber syndrome.
Hamdi has a good question. She wants to know, is it possible to know how the disease will progress in the baby? Is the effect of Sturge-Weber worse in patients with seizures at an early age?
It is. So onset of generally speaking, again, every child is an individual, everyone is different, but prognosis is largely dependent on age of seizure onset. So seizure onset under somewhere between 9 months to a year is poor prognosis, and then seizure onset or extent of brain involvement. So a child who has extensive bilateral brain involvement or all of one side involved, as opposed to just a small area on one side, has a poorer prognosis than just the smaller area of involvement. So, and the third factor, which has less of an impact on involvement, is extent of the birthmark.
So another question from Jiang Zenling wants to know, could you comment on the potential long-term negative impact from taking pre-symptomatic treatment, and are they expected to continue for life? Maybe the aspirin.
So potential side effects from low-dose aspirin can include bruising, nosebleed, gum bleed. Usually those are not a huge deal in infants. They can become a bigger issue in toddlers or young children who are running around, and so we have to watch for those. Very occasionally, we might see a child who has issues with stomach upset and need to also put them on something like Zantac to protect the stomach. Very, very, very rarely So the vascular malformation in the brain in Sturge-Weber syndrome doesn't bleed, which is why, on another note, they should not be getting head CT every time they go to the hospital for a seizure or a stroke. If the doctors feel like they need to image, an MRI, rapid MRI or MRI is much better because there's no radiation with that. Okay, but but it's very rare, very, very rare for it to bleed. But rarely we can see small areas of like subdural bleed either on aspirin or off aspirin. Obviously, if we were to ever diagnose a small subdural bleed, we would take them off the aspirin because any kind of bleeding is going to be increased if the child is on aspirin. It doesn't increase bleeding like Coumadin or heparin. Those thin the blood a lot. Aspirin thins the blood a little bit. Sometimes parents worry about Rye syndrome because they've been told, don't ever put your child on aspirin because it increases Rye syndrome, which is a terrible thing that used to happen in association with aspirin. Rye syndrome is not associated with low-dose aspirin. It was associated with much higher dose aspirin used for pain control or temperature or for fevers. So there's not a known long-term problem associated with aspirin use in terms of like cognitive or developmental issue associated with aspirin use. In terms of anticonvulsants, so oxcarbazepine or levetiracetam Keppra. Several years ago, there were animals like mouse and rat studies with anticonvulsants suggesting that seizure medications in baby rats or mice could cause developmental issues in the brain. It's very difficult to sort of separate, to translate those results into results in babies. We don't offer those medications to children who don't have a risk of stroke and seizures and abnormal development. So we don't put children who don't have a very high risk of seizure and stroke on seizure medicines. It's true. And also, when I have the discussion with families about whether or not to start pre-symptomatic treatment, I'm much more likely to offer it and suggest it if the extent of brain involvement is high. So they have much of one side of the brain involvement or they have bilateral brain involvement rather than if they just have a very small area of brain involvement. Because if they have pretty extensive brain involvement, then the risk of having fairly early seizure onset and or eventual neurologic and developmental abnormalities, stroke, significant epilepsy is quite high. And we want to prevent that.
Yeah.
So if we can even delay seizure onset until they're children or prevent it altogether, then the brain is allowed to go ahead and develop, can prevent strokes, we can allow speech development, cognitive development over those first several critical years of life.
Yeah, and I think you and I have talked about now that you and your team have discovered that GNAQ somatic gene mutation, that there is hope for the future of therapies.
So that's true. We have been studying more targeted treatment, and additional more targeted treatments are being studied for vascular malformations and somatic mutations in general. And so that's going to continue to sort of be coming for us and being studied. So absolutely. I mean, I don't know that the pre-symptomatic treatment of choice will always remain low-dose aspirin and an anticonvulsant. But that's what we're working with right now.
Right. So Mahela Bobam, she's a big follower of VBF for 7 years. Wherever we go, she goes to get the laser for her daughter because they're from Croatia and there are very few options. Yeah. She was asking a question about the Prima laser. I know Dr. Cohen was, looking to get the Prima laser. I know that she wanted to know about, early results. I know that Dr. Nelson and Dr. Geronimus have told me they're seeing some promising results, but her question to you is, and I know you wouldn't know, you don't get that information, but her daughter's 7 and does have the location for Sturge-Weber, and she's never had an MRI, so she wants to know if she should get one done now.
So it can definitely be done now, and would rule out brain involvement, and you could consider doing it now, or you could consider waiting another year or 2 when she probably would be able to do it without sedation. I mean, it really is up to you, I guess, and choices that you're looking to make right now. So, if you're thinking about sports and activities for her right now and you want to get this out of the way, or you're thinking about have other questions and just want to settle this question, then getting the imaging done now could exclude Sturge-Weber syndrome brain involvement. If there's no choices that need to be made right now and you're happy with waiting maybe another year or so when she could get it done without sedation, you could do it that way too.
Okay. Lisa wants to know if an MRI is normal at birth, get it done again at 1.5 years. Would you repeat it again later in life? For example, 4 if they're all clear.
That should not be necessary.
So if it's clear before and then clear at 1.5, it's pretty clear. Okay. Yep, that's good question, Lisa. Heather wants to know if you're open to answering, how did you get into studying Sturge-Weber syndrome?
Sure. Okay. So I was finishing my pediatric neurology training at Johns Hopkins and looking to going into a 5-year research training program, an NIH research training there, and knew I wanted to go back, do a translational research. So research program focused on a pediatric neurology disorder and work in the lab, have a lab program, a clinical research program, and see patients. And I had seen patients, a few, with Sturge-Weber syndrome before, and met with Dr. Michael Johnston, and at that time, was looking at different options. And he said, I was invited to an NIH consensus conference on Sturge-Weber syndrome, and I can't go. And why don't you and Jonathan Pesner go and meet with them? And so we went and we met with a few of the doctors at that time who were involved, and there really was very few physicians and researchers who were seeing patients at that time. And I started seeing patients, and they were wonderful. And I think the thing that really got me at that time was that the babies are born with a birthmark that is a sign that they are at risk for Sturge-Weber syndrome. And if we can diagnose them early enough and figure out how to treat them preventatively, prevent the seizures, prevent the strokes, we could really change the trajectory for Sturge-Weber syndrome. And obviously I take care of the patients who have already had all of that happen, but it still gives me like the chills to know that, we want to figure out what causes it. We've done that. And then how to better diagnose it, how to preventatively treat it, and maybe someday how to cure it. And that's, still why.
I think, again, to restate it, because it's so important, that pre-symptomatic treating, like, let's not wait for this or this or this to happen, but let's get to treat now, and then hopefully you can stave off some of the worsening. So Joan wants to know, her daughter has a port wine. She's in her late 20s and now seeking Sturge-Weber diagnosis. She has migraines, light sensitivity, and the pigment is changing in her eye. Are seizures a given to watch for in her future? Will an MRI help discover this? You met her at our conference in October.
How old is she again?
She's 20, in her 20s. So it was Brock Schmidt.
I mean, an MRI should be done. I mean, we need to know whether these symptoms are all eye related, and so the eye needs to be evaluated and make sure that
the light
yes,
sensitivity
right, because
changing
glaucoma can cause headaches as well. So if there's increased pressure in the eye, then that can cause headaches, and certainly light sensitivity. So that needs to be evaluated. But then, in order to know if there's Sturge-Weber syndrome brain involvement or not, the appropriate MRI imaging needs to be done. And if there is, then that can be treated. Typically we treat with migraine medications, and so yeah.
So Lee Chen has a good question. He wanted you to elaborate a little more on what does this early handedness mean on one side, or early handedness that you were saying, and what does the one-sided gaze look like?
Okay, so I was talking about babies.
Yeah, and he was saying it's his baby.
Right, so let's just say the baby has a port birthmark on the right side of the face, and we don't know if the baby has brain involvement or not. And so if the birthmark is on the right side of the face, we're worried about brain involvement on the right side of the brain. The right side of the brain controls the left side of the body, okay? And so children should become handed, all right, before like 1.5 years of age, certainly not under 1 year of age. Most of us are right-handed, okay? And so some parents will think if the child starts using their right hand more, okay, that at like, say 6 months of age, that they'll say, oh, my child's just, they're right-handed. I'm right-handed. The child's mother is right-handed. The child's just becoming right-handed. Well, that's not normal at 6 months of age. Okay. What's happening is the child, in fact, has right-sided brain involvement. They're becoming weak on the left side. Now, maybe they've actually had some seizures that have been missed. Okay, whether they maybe happened at night or they were subtle and just weren't picked up, that can happen. And so they're developed. It's not that the right side is stronger; it's that the left hand and leg are weaker. Okay, so handedness under 1 year of age, significantly under 1 year of age, is not normal. It's not that the one side is stronger; it's the other side is abnormally weak. And that's something that should be brought to the neurologist's attention right away, okay? So the visual gaze preference is this. So again, let's say we're worried about the right side of the brain. The occipital lobe is a very most commonly involved area. That's the back of the brain. The occipital lobe, it processes vision, okay? And the right occipital lobe processes vision here. I'm gonna move. Can you see me?
Yep.
Okay, so processes vision sort of in front and then off to the left. Okay, so what can happen is that the child, they don't see well off to the left, and so then they'll start paying attention only to things over to the right. Okay. So, and so if you're over to the right, they'll pay attention to you. They'll look at you. All right. But then if you move over to the left, they act like you're not there. Okay. They'll just stop looking at you. And then you go back over to the right, and now they'll look at you again. Okay. So that's called a visual field cut over here, or a visual gaze preference to the right. Okay. The other thing that they might do, again, if they can't see off to the left, is to they'll turn and look at you with, they'll just sort of bring these right side visual fields that they can see with, and they'll turn and look at you like this. So they'll have a head turn and bring the visual fields that they can see with out and just turn and look at you like this. So if you see that also, and parents are oftentimes pretty good, you have to bring that to the attention of your doctors. And if your pediatrician says, "Oh, it's fine," well, you have to insist that that's not right.
That's very informative. So Shayla Johnston said that her son has had 2 seizure episodes at 6 months and again at 8. He's almost 1 and hasn't had any more seizures since being on 2 seizure meds. He is developing on track. The MRI showed mild brain developing.
So a really important thing is it's great that the seizures have been controlled. A really important thing that I tell parents when they come is that it's super, super important to every few months weigh the child and increase the dose of their seizure medicines, because otherwise they will outgrow the dose. It's really, really important. A lot of times neurologists or doctors will be like, "All right, no seizures, great, that's perfect." And they don't increase the dose. And over the first year or so of life, the child will double their weight and then they'll seize again because they've outgrown the dose of their seizure medications. So every 3 to 4 months, the child has to be weighed. And if they've gained 5 or 6 pounds, the dose has to be increased to keep the milligram per kilogram per day dose the same, or they outgrow it and then they'll seize again.
I have a question. So when patients with Sturge-Weber syndrome get to the point where their seizures are not controllable, is that when they look at the hemispherectomies?
Yeah, so if they've failed at least 2 seizure medicines, and for me also low-dose aspirin, okay, and they're over a year of age, the risk of bleeding and morbidity and mortality is greater under a year of age, okay? So if they're over a year of age, they've failed at least 2 seizure medicines, and oftentimes it's more than 2, but at least 2 seizure medicines and low-dose aspirin, and only one side is involved. If there's bilateral brain involvements, in desperate situations, seizures or epilepsy, surgery is still considered under desperate circumstances, but typically surgery is a good option when only one side of the brain is involved. Yeah, and seizures continue. Occasionally surgery may be considered even when there aren't very many seizures, but when the child is cognitively and neurologically it's falling further and further behind.
Ashley says, "Hello, my son Jackson is almost 6. Okay. He was born with Sturge-Weber syndrome." Sorry, this is a long one. "Knock on wood, so far his biggest complication is he has glaucoma in both eyes. No sign or history of any seizures. In the last week and a half, there have been 2 occasions where he has lost feeling in his left foot for around 20 minutes, and both times was after he had been awake for an hour or so. He can't wiggle his toes. He can't feel me touching or tickling the bottom of his foot. And if he tries walking, he falls. Have you heard anything like this with Sturge-Weber? What should we be doing or saying?"
How old is he?
He is 6. He's almost 6.
That is a very unusual history. I would definitely be talking with this doctor and getting EEG done. And I would want to know does he have birthmark on his body? I would want to know what his imaging looks like in detail, but that's a very unusual history. So I'm not sure
so
what to say about
she
that.
can follow up and send you more details through
Yeah.
the VBF website, give you more information. Ricky again wants to know, again, like this, what is the best course of action to take in helping with the field cut vision? I know it's a brain issue and not eye. What can be done to help the vision come back?
So I have seen repeatedly the visual field deficit come back with initiating low-dose aspirin. So if the child isn't, or patient is not on aspirin, then that can be tried. And I've seen that improve it many times. The other is if seizures or stroke-like episodes are happening, then we aggressively work to improve the migraines or control the migraines, control the seizures. And if those are controlled over a prolonged period of time, then the visual field can also go away when those are under control.
Well, that's great. Zenling Jiang said, to follow up on the question with the gaze problem, the visual gaze, if we suspect our baby 3 to 4 months old to have visual gaze or handedness, what kind of intervention should we be doing right now?
So you should call your neurologist if you have one, or pediatrician if you don't, and if they should get imaging done to diagnose brain involvement if brain involvement has not been diagnosed. And once brain involvement is diagnosed, then I would certainly have a discussion with them about initiating. At this point, it wouldn't really be truly pre-symptomatic treatment, because I would consider the visual field cut or the handedness to be symptoms. It's before the onset of seizures, but that child is at very high risk. If they're already having handedness or a visual field cut, they're at very high risk for having seizures start very soon. Yeah.
Okay. So Ashley, she had the one I said to send you more information, said yes, his birthmark is on his face, stomach, back, right leg, and left arm.
I see. So
he's got extensive involvement.
So that child needs to have additional imaging of the body done,
Mm-hmm.
okay? Because they could have deep vascular abnormalities affecting the abdomen, the groin, the legs, and so there could be multiple reasons for why the symptoms in the leg could be taking place.
Oops. Sorry about that. Right here.
So that child needs to be studied further by a vascular anomalies group
Expert.
Yes.
So this is an interesting one. Nitu Mariana from Germany says her daughter is 15 months. We had an MRI at 8 months. Unfortunately, changes in the brain have occurred. Discrete atrophy of the right occipital lobe
Yes.
and correlative leptomeningeal enhancement
Yes.
compatible with Sturge-Weber.
Yes.
The port wine is on the upper eyelid and right forehead. It is a large area of a large area of the brain affected? She is seizure free. Maybe is this considered a large area?
That is not considered a large area. If it's only what you have written there, that's just the occipital lobe on one side of the brain.
The upper eyelid, yeah.
Well, so right. So
the stain.
Right. So that is not considered. And how old is the child?
She said
8 months. Okay.
8 months.
All right. So no, that is now.
Oh no, she's 15 months.
Okay.
But she had the MRI at 8, and now is having the changes.
So no, that's not a large area. The only caveat being that when imaging is done earlier than a year of age, it can underestimate the extent of brain involvement.
Okay, that's why you said.
So, in order to know for sure if that's fully the extent of brain involvement, now I'm not saying you have to get imaging done, but to know for sure if that's the full extent of brain involvement, let's say you were considering pre-symptomatic treatment, imaging would need to be repeated after a year of age. Again, MRI with without contrast, SWI imaging, post-contrast flare, all the sequences to be sure that you know the full extent of brain involvement. But what was there at 8 months, if that's all that was there, and again, I'm not looking at the report, but if that's all that was there, that is the smallest extent of brain involvement that we would see, just the occipital lobe on one side.
Okay, so we can only do one more question because it's almost 2:00. And people can go back and rewatch this because you've answered some of these questions, and this is a repeat. Luisa's baby is 6 months old with a facial port wine. Eye exams are normal. We were told to wait for an MRI till 12 months, which is what you've said. And she wants to know, should it be done sooner than 12 months?
So you could get an EEG. So how old is the child?
6 months
6
with
months.
a facial port wine.
Okay.
Eye
So-
exams are normal.
Right. So I do an EEG. So you could get an EEG. I do a history, an exam, and an EEG. So you could do an EEG. That's completely safe, steady, no sedation required, no contrast. It's like an EKG on the chest, only put the leads on the head, and it reads the brain waves. And if there is significant asymmetry, meaning less power on the side that you're worried about, because that's the side where the birthmark is, or there's lots of sharps or spikes. This is ictal activity suggesting an area of the brain that is prone to seizing. Then you would consider getting imaging done earlier. And knowing that if at any time concerns developed about development or episodes that look like seizures, that you would go ahead and get the imaging done. But if everything looks okay, history, exam, EEG, then going ahead and waiting until after a year of age makes sense.
Okay, well, it's been a very informative session. Thank you.
Thank you,
and
Linda.
Taking the time out
My
from
pleasure.
visiting your family
Sure.
for Thanksgiving. And again, you can all watch this as many times as you want. And Dr. Comi will be back next year
That's right.
at the same Thanksgiving weekend. And remember, everybody, next month is very important. It's the psychosocial implications of living with a vascular birthmark, and especially dealing with the holidays when you do have one. So thank you all, and thank you, Dr. Comi, for being here with us. And try not to go out too much today. It's Black Friday and a lot of traffic and a lot of crazy shoppers.
Take care, everyone.
Yeah, thank you.
Bye.